And speakers to please come to stage. It gives me great honor to first invite Dr. Ahmed Arman Siddiqui, CEO and board member, Grameen Health Tech Limited, and acting CEO, Samadhan Services Limited. Dr. Ahmed Arman Siddiqui, could we please have a huge round of applause? I'm now requesting the speakers to take stage. Professor Dr. Mohammad Saidur Rahman, Special Assistant to the Chief Advisor, Ministry of Health and Family Welfare, Interim Government of the People's Republic of Bangladesh. Could we have a huge round of applause for Dr. Rahman? He's been very patient with us. He stayed throughout the proceedings, and we thank you for your time, sir. Next, we've got a friend coming all the way from Germany, Tobias Silverzan, CEO of A Healthier Future GmbH. Tobias, if we could please request you to take stage. Thank you, Tobias. Then we have Dr. Khalida Hanum Akhtar, former Chief of Party, USAID, DFID, NSH, DP, and Senior Country Representative of Pathfinder International from Bangladesh. We're being joined online by a very special guest, Professor Rajendra Pratap Gupta, who's the Chairman of Internet Governance Forums DC, Digital Health, and Chairman of Commonwealth AI Consortium for Capacity Building all the way from India. He'll be joining us via Zoom link. And of course, we've got our dear friend, Dr. Scott Leckman, General Surgeon and former Chairman of the Board of Directors of Results and Results Education Fund. Dr. Arman Ahmed Siddiqui, the floor is yours. Thank you. Ladies and gentlemen, this is a timed session. To the moderators and speakers, you will hear the first bell in 30 minutes time. Can I have a demonstration?
We have got the other speaker, please. Mr. Ashraful Hasan is here.
Oh, wonderful. Could I now also invite on stage the Chairman of Grameen Group, Mohammad Ashraful Hasan. We're ready for you, sir. Could we have a huge round of applause for this brilliant plenary session? What better way to kick off this conference proceedings than this one? Now, just letting you know again, moderator and speakers, first bell in 30 minutes, second bell in 45, third bell in 55, and the last bell when the session ends, and there'll be two bells. Dr. Ahmed Ahmed Siddiqui, I request you to please commence. Thank you.
Thank you so much, Promi. Good afternoon, everyone. Good afternoon. I can see some waving of the hands, and it's been an honor to be here, to actually be here as the first plenary. For your information, our chief advisor is still excited enough not to leave the premises, or maybe he just left the premises. That's why we got a little bit of delay, and we are really sorry about that. I'm sure you're having a very good time so far with the wisdom of the speakers and the enlightenment that we have gone through. This plenary is about 3D. This 3D means the transformation of healthcare through democracy, demographics, and digitalization. And I was extremely happy to hear from Professor Yunus about the situation of war and the uncertainty that we have got in our scenario. And healthcare is also not an exception. So without the further ado, I am excited and very much overwhelmed to have extremely amazing distinguished guests along with me. And I don't dare to introduce them. And I will actually love them to introduce themselves. So I would love the speakers here to kindly introduce themselves. And I hope Gupta is there online. Is Gupta online? Can I hear from Gupta? And can I see his video, please? And meanwhile, sir, over to you for the introduction, please. Oh, yeah, I can see Gupta. That's great. Can we have him flashed in the main screen, please? Yes. Gupta ji, you are listening to me, right? Can you hear me?
I can.
So let me start from you on the introduction, please. Could you please introduce yourself in a minute?
Thank you, Arman. It's great to be here with you for the wonderful work you are doing at Professor Yunus. I would greet him happy birthday in advance. I'm Dr. Rajendra Pratap Gupta, former advisor to the Health Minister of India. I've also contributed to your AI policy for the government of Bangladesh on the invite of the Prime Minister in 2019. I am a part of the Commonwealth AI Consortium for Capacity Building. I chair that. I'm also the United Nations IGF's Dynamic Coalition on Digital Health chairman, and been working in digital health for a long time and a great friend of Arman. Pleasure to be with you.
Excellencies and distinguished guests, Assalamu alaikum and good day. I currently serve as a special assistant in the Ministry of Health and Family Welfare. I have a background of medical academic and former Vice Chancellor of Bangladesh Medical University. Actually, my public life and journey started during my medical student period, and that was actually based on commitment to justice, equity, and right to health. I have a little bit of contribution in progress in development and formulation of some of the national policies like rational use of medicine, antimicrobial resistance, pricing of medicine, and drug safety. In addition, I have supervised almost around 100 research projects. And during the last 2 decades, I've worked to actually change the landscape of medical education and the health services, particularly with the introduction of digital innovations. But I believe that the technology alone cannot deliver lasting change. So true transformation must be rooted deep into participation. It's my profound honor that I'm able to join in this gathering and united by a shared vision of equity and inclusion. Looking forward to learning from all of you. Thank you.
Good afternoon, everyone. It's an honor to be with you all. I'm Tobias Silbertson. I'm originally a biochemist and immunologist and did cancer research. And my passion is really to improve health and well-being in the world. Over the last 15 years, I had the pleasure of working with startups on digital health, with ministries of health on digitizing health systems, with the World Health Organization on digital health and innovation. And the last couple of years, I've had the honor of working with Professor Yunus, with Ashraful, with Aman on what could digital health and what could a digital health platform for Bangladesh look like. And that resulted in Shuki, so happy to talk a little bit about that today.
Good afternoon. I feel honored to be a speaker in this plenary one, and thank you very much. I'm a reproductive health epidemiologist and was a family planning clinician at the early life, and now a strong advocate for enhancing public health concept for the full life cycle approach. I spent over 45 years advancing women's health and rights in Bangladesh and abroad through clinical services, reproductive health research, and large program management. With master's and doctorate degrees in public health from Johns Hopkins University and completing my 2-year Centers for Disease Control EIS, Epidemic Intelligence Services training from Atlanta, Georgia, I have founded and led major institutions, and most important of them is Bangladesh Institute of Research on Reproductive Health and Technology. I was Director General Family Planning Association, also Chief of Party of the Smiling Sun Project, and contributed in shaping national population policy and strategies, and most importantly, post-Cairo conference, the post-international conference on population and development in reproductive health, maternal health, contraception, and women-centered healthcare. Starting at the beginning of my career, I had opportunity to provide critical services to Birangana women in 71, and founded a grassroots level program in Rangpur. I was honored with many national and international awards, including United Nations Population Award in 2006, Begum Rokeya Padak, and also Bangla Academy Fellowship. I would also like to mention that I'm very privileged to be a member of Women Affairs Reform Commission of Bangladesh government, and I love to advocate for public health leadership, try to project courage, integrity, and unwavering commitment to the rights and dignity of women. Thank you very much, sir.
Assalamu alaikum. I'm Scott Leckman. I'm a general surgeon from Salt Lake City in the western part of the United States. I am a board member of Results, and it's a nonprofit advocacy group. And that's what brought me first to Bangladesh in 1992, where I got to meet Professor Yunus. We went out to the villages, we walked with the bank workers, we interviewed the Grameen borrowers, and that experience affected my life in deep ways. And I was able to go back to Washington to lobby my members of Congress about actions that they can take to help end poverty. I am just surprised and pleased, so pleased on the recent events here in Bangladesh. It's a historic time. You have a chance to recreate the country, and this is for the history books, and you're living it.
Thank you so much.
Assalamu alaikum, good afternoon. I am Ashraful Hassan. I started my career in 1984 in Grameen. I was responsible for infrastructure development of Grameen Bank. And in 1999, I retired from the bank and joined in the group companies. So I worked in textile, telecommunication, manufacturing, distribution, sales, lot of things, lot of diversifying works I have done. Actually, what I did the last 41 years with Grameen, what Professor Yunus' visions and ideas I try to implement. Most of the things, what he wants, I try to build it. This is actually my introduction. Thank you so much. Now I am chairman of Grameen Bank, a Grameen Group.
Thank you very much. Thank you so much. Is the voice audible or it's too much having a delay? Kotha ki bodha jacche? Ekটু হাত তুলি? Okay, that's great. Thank you so much. Thank you so much, ma'am, and thank you so much, gentlemen, for this splendid self-introduction. So, this is a very interesting topic, the 3D of healthcare, democracy, demographics, and digitalization. And as usual, democracy comes first. I can see another veteran persona in front of me, Nurjahan Appa, watching us and, trying to grab like whether I'm really talking sense. So I'm a little bit of nervous about that, but I'm happy that I have got the right person beside me, Professor Saidur Rahman, who actually understands it so well, being the former VC of BSMMU, and also I know how he's driving the forces. And I know the intention of really serving the population and serving the ecosystem. So the first question on the democracy to Professor Saidur Rahman is, how can government put patience? I put another option, but he asked me not to put that. So I will not say that politics. I will say, how can government put patients at the center of healthcare policy through participatory governance models for semi-urban and rural Bangladesh?
Thank you. Thank you very much for your thoughtful question. But as you mentioned, before I respond, please allow me to reframe it again a little bit. Just to align with the spirit of this session, instead of asking, how do we put patients at the center of participative governance in healthcare for poor, urban and rural people in Bangladesh, I would love to make it in a better way, like, how do we place people at the center of participatory governance in health and well-being of the rural and urban people of Bangladesh? This is more than semantics.
A round of applause for that.
This is actually a philosophical and political reorientation. When we say patients, we restrict people to their illness. When we say healthcare, we limit ourselves to hospitals, prescriptions, and medicines. But health is not a service we consume. It is a condition we co-create. As Dr. Zafrullah Chaudhry said, healthcare must be a tool of empowerment, not a privilege for a few, but a right for all. And in Bangladesh, we are trying to uphold that vision of health as a matter of justice, participation, and dignity. We are reinvesting in primary healthcare, not just as infrastructure, but as a community-based democracy. That is a democratic practice because we know the local health worker was once not just a caregiver, but a trusted neighbor, a human link between the science and society. That is the model we want to restore. And we are reshaping medical education accordingly to produce professionals who are not only technically skilled, but socially rooted, capable of co-creating solutions with the communities they serve. Alongside with this, we are moving beyond over-medicalization of health. We are actually exploring a more culturally grounded approach that reflects how people actually live, heal, and understand well-being. Digitization, when done ethically, can also be a great equalizer. We are building digital health platforms and Bangladesh to connect periphery with the center, ensuring every household counted, every voice heard, and every service tracked. When communities see their own data, exclusion becomes visible, accountability becomes inevitable. Actually, participatory health governance, that is actually the school for democracy. So when people shape decisions about their health, they set their priorities, allocate resources, and track outcomes. They begin to act as citizens rather than as subject. As Professor Dr. Muhammad Yunus wisely reminded us, poverty is not created by the poor. It is created by the system we build. So too is ill health. It is not simply a biological condition. It is often a social consequence of exclusion, voicelessness, and structural neglect. So by creating systems where people don't just receive health, but govern it, we lay the foundation for broader democratic participation in education, in local government, and in the state. So participation is not just a governance model. It is a moral and civic project. And if we do it rightly, we may not only improve health, we may renew and reinforce democracy. And at the right point, that is where it truly matters, that is on the people for the health. Thank you.
Fantastic, fantastic. So, thank you so much, Sadar Rahman sir. And this is great that already the digitalization is taking place, very much correlated. And that actually brings me to the next question to Dr. Halida Hanum. I mean, we all are overwhelmed by your profile and you had a lot of experience. Could we have some idea about you on the ultimate implementation of proactive care? So this proactive care, will that be a myth or it will be, or there is a light at the end of the tunnel? So with the interest of time, we want you to finish in 3 minutes if it's okay. And could we have the slide very quickly on the screen, please?
Next slide, please.
Yeah,
Um,
next slide.
Right. So the question was like,
Put it in the PowerPoint slide,
Right.
presentation mode.
Right.
Thank you. For a slide.
next slide. Then. So the question was that how do I foresee the ultimate implementation of proactive healthcare, right? So I'm going to explain what is proactive healthcare, and your question was also like, will this be a myth or good, for good, or there is a light at the end of the tunnel?
So, Appa, can we skip what is proactive healthcare?
Yeah,
Rather,
no, I'm
let's
saying
go-
that-
Let's go to the solution. So, if you change the slide quickly,
Yeah, change the slide.
change the slide.
So the we usually call curative care or public health care or preventive care, but this proactive health care is a new language. And I think it's very interesting. And what does it interpret? It means that it represents a transformative vision for the future of curative medical care and public health. So it's a combination. And the proactive healthcare aims to prevent diseases, manage health risk early, and promote long-term wellness. Whether this ideal becomes a reality or remain a myth depends on several factors, but there is definitely there is a light at the end of the tunnel. Why I say that? The ultimate implementation of proactive healthcare, as I have seen, is likely to involve several factors. One is combination of technology, personalized medicine, policy changes, and cultural shift. There are some key domains that proactive healthcare could manifest, and I have 4 domains. One is preventive care revolution, other one is global accessibility and universal health coverage, and integration of artificial intelligence and big data, and digital health ecosystem. Next slide, please. When I look at the domains, if you look at domain 1, the preventive care revolution, it includes vaccine and immunotherapies, proactive global vaccination campaign. Immunotherapies could reduce infectious diseases and also prevent some form of cancer. So once we have this immunological vaccines available. Also, the lifestyle medicine is very popular now. The greater emphasis on nutrition, exercise, mental health, and sleep hygiene could prevent up to 80% of the chronic diseases like diabetes, hypertension, and obesity. And the domain 2 is also global accessibility and universal health coverage. Like proactive healthcare must be accessible to all, regardless of their economic status or where they live. Also, the universal health coverage could ensure that preventive services like screening, vaccine, they are available to everyone. Also, the domain 3 is important because integration of artificial intelligence and the big data is very much needed. And I'll be talking that these are also important for the National Health Services. So proactive analytic is important, analytics is important. And like AI-based machine learning can analyze vast amount of health data, generic information, lifestyle choices, wearable devices. They can predict individuals' health risk also. And early diagnosis. There are many diagnostic devices are available like smartwatches, continuous glucose monitors. These can track the real-time matrices and detect abnormalities early. And also the personalized intervention. A AI-driven platform can design customized health plans, prevent or delay onset of chronic diseases based on individual risks. This is a new concept, but we have already been practicing. That's good.
Yes,
thing.
madam. So, I mean, that's a fantastic point that you mentioned about the AI and the prediction. And we
Yes.
have got an expert here, and that's where I am going.
Right.
Actually, Dr. Tobias.
Digital health, yes.
Yeah. So, the question I have for you is, you often say data can predict disease. Can it also predict equity or the lack of it? You can take the microphone from Tobias, from Dr. Halida.
Thank you. Well, I would say it's often relatively simple to spot that by looking at the methods that organizations employ when they design healthcare innovations or healthcare solutions for a certain citizen segment or a population segment. And whether they use people-centered design, for example, or whether they are not using that and just building something. But an example that I would like to share here, given that there are lots of change makers in the room, is the example of Stop Tuberculosis Partnership, an organization that tries to end tuberculosis. And they are using people-centered design when they think about what to design and what to implement in a country and with a country. For example, when they are working with Vietnam or Uganda. And in this work, they've included tuberculosis patients, tuberculosis survivors, nurses, doctors, in actually really understanding what the problem is, where the process doesn't work. And then they didn't stop there. They also included the tuberculosis survivors, for example, in prioritizing which challenges should be addressed and what should be implemented. So just imagine that in Vietnam, there was the head of the National Lung Hospital sitting next to a TB survivor, and they were both prioritizing together what should be done in terms of digital health for tuberculosis. And then the solutions were co-designed with the patients and the nurses and the doctors as well. For digital health and for our discussion here, right, I think that it can mean three things. It can mean doing health not just in person or not just digital, but as a hybrid health approach where you combine digital health with physical locations where the people are. Secondly, I think it means including channels that reach the citizens where they are, right? That going to pharmacies and are working with pharmacies that includes channels like WhatsApp where people are, for example. And thirdly, it means, in my view, building the health competency of the citizens, that they know better about health and well-being and are more informed in taking the decisions that are helpful for them. And to do that well, in many cases, that means to make health and well-being fun for people, which often is not the case in healthcare systems traditionally.
Yes.
So in that sense, I hope that also in digital health and hybrid health, what Shuki is doing, given the name as well, that we can make health and well-being fun for citizens in Bangladesh.
Yes, and sometimes I ask my CMO like why the app download is not that much. He says people will use it when they will need it. So you cannot really, push it like that. And now on this euphoric scenario on the digitalization and AI, we always see the policy that plays a pivotal role. And that's where I'm gonna go to my mentor in the Southeast Asia, Gupta ji. I hope you're listening to me. As the policy maker, please enlighten us who or what or how should be setting the digital health agenda for the Southeast Asia region and beyond, the proactive healthcare and the AI and the digitalization that we are talking about. How can the policy be supportive in our part of the world? Over to you, Professor Gupta. Can we see him, please? Can we flash Professor Gupta's video?
Yes, Arman, I'll start while your technical team puts the video on. So I'll give you an experience of my being a policymaker, and being an ordinary citizen in the first place. Way back in 2013, I was asked to draft the election manifesto of the party that runs the government now. And as someone who worked in health, I decided to prioritize what should health need in the first place. If you run a country of 1.35 billion at that time, my priority was health, education, infrastructure. Health was at the top because without health, neither you can have education, neither you can have infrastructure. People won't deliver. Within health also, I first prioritize policy. I know a lot of my bureaucrats hate policies because without policies, they have freedom to do what they want the way they want. But I am a believer that you need to have policies in place first, and then you need to have monitoring and evaluation, and on a routine basis, milestone-based changes as you get along. So let me give you the results of what we did. And that also sets a template, not just for South Asia, but for any part of the world. Always people have said policy is behind technology, which is true in many ways. But look at how we have handled it. We came out with a national health policy in 2017. We set up an institution. I was very clear that people alone cannot do things based on projects, programs. We need to institutionalize digital health. So I set up the National Health Authority that would take care of the National Digital Health Mission. That was a part of the National Health Policy that we built, for India. So what has happened in this few years is 780 million plus health IDs rolled out. We set up eSanjeevani, which is the largest telemedicine platform in the world, on which now I'm writing my 6th book. We have done over 350 million consultations. Every single day, you can see a dashboard on the web for both the National Health Authority and the telemedicine platform. Daily, we do almost like 300,000 consultations, teleconsultations every day. And I created a price model for that, which is there on the Health Parliament website. If you go to parliament.health, you can download that. So what I have put is you need policy and planning as first order price. Then you need resources. Then you need institution. Unless you institutionalize digital health, you will not be able to deliver as a country. Institutional implementation, then collaboration and capacity building. If you do not have capacity building, you will not be able to leverage digital health to full potential. And the last part of price is E, which is evaluation. So if you follow the price model, I think we can do it. But going back to the short answer on the question, who should decide? I think enlightened policymakers, and forums like this that you are hosting, not only is for Bangladesh, but for every country to look and learn from the discussions you are having. And I loved what my fellow panelists said. We have gone to over-medicalization of healthcare. I'm a firm believer that digital health will kind of trim it down and make it more democratic as healthcare democratizes with AI. I'll stop here and probably wait for the next intervention when it comes. Thank you so much.
Thank you, Professor Gupta. And I always tell this to Nujahan Appa and Professor Sadur Rahman that the previous interim government has given us the NID. I have, and we have an expectation that this government will give us UHID. That is a very long pertaining initiative that we really have to ensure. The same like the Aadhaar card that we see in India. So we will also have Adhikar card or something like UHID, and we are waiting for that days, inshallah. Maybe the time that we have. Let's hope for the best. Now I will go exactly, to the opposite direction of the world, which is the North America. I have got a gentleman here, very lucky to have Pakistani Qaris at his home. So he understands the dynamics of Southeast Asia, and I see how he's connected with Professor Yunus. And he lives in such a country where the policy, the democracy, the demographics, everything comes out really great, but it's a hefty insurance-driven policy, which sometimes wonder for us, like whether, how here social business can add value. In case of the North American market, compared to UK, the fragmented Obamacare, how that digital divide for US could be addressed with the help of the social business and the healthcare. Over to you, Dr. Scott Lakeman.
In the US, we have a fragmented payment system. And with anything fragmented, there are going to be people that fall through the cracks. So there is 8 to 9% of Americans who are uninsured. And that amounts to about 26 million people. I have tried my own hand in my corner of the world to try to fill in that gap. Back in 2001, I, with the help of others, started a program to offer comprehensive health care to individuals that made too much money to qualify for a government program, but not enough money to buy private insurance. And I've got all 4 healthcare systems in my county to buy into this, and got more than 600 doctors in the county to provide charity care. And that did well for a couple of decades. And during this time, the for-profit hospital systems bought up most of the doctors, who were then unable to say whether they could give charity or not, because they now had bosses. And the hospital systems had the social workers that made the system work. So they withdrew their support. So after 23 years, it died a natural death. Professor Yunus has been trying to convince me that charity is not sustainable. And of course, he's right. So we have a system in the US. It's dominated by profit motives, both insurance companies, hospital systems, pharmaceutical companies. So, and I can't tell you how much it pains me to watch revenue generated in the healthcare system exiting the healthcare system and going into the pockets of investors. So I would love them all to be replaced by social businesses. Now, in the US, we have some challenges. We have legal, regulatory challenges. We have financing challenges. Investors want a return on their investments. So, but there's possible solutions to all those. There's going to be, as the price of healthcare continues to climb, we spend more money than any developed country on healthcare, and we have among the worst health
Maybe public health support.
public health statistics. So we spend a lot, have little to show for it, mostly because of this gap that we've been talking about. So I see a growing dissatisfaction that will continue. And one side will say, well, let's get more government funding to fill in that gap. And the other side is going to resist that. And I think that is the opportunity for social business. But people need to know about social business, and that's where we need to do our work.
I'm very hopeful here. A round of applause for Dr. Scott, please. Thank you so much for an excellent, vision. And the Grameen America, I mean, it's such an amazing use case. I mean, who could think that, that model would actually deploy there and the vision of Professor Yunus would be implemented so far. So talking about the social business, let us hear from the maestro, the wingman of Professor Yunus, our group chairman, Ashraf Rasul sir. Sir, in 3 minutes, we have a pressure for the Juma prayer and lunch. Like how Grameen as an ecosystem ensured the implementation of social business in the healthcare. Just give us some practical facts. I know you could talk about 30 minutes about it, but you have to cut it short and give us the insight.
I'll try my best level. So actually, Grameen is always try for new ideas, and healthcare is always been our focus. So actually, we started with health in 1996. Grameen Kollan, I just say about Grameen Kollan in my speech. Started for rural health, primary healthcare service. From 1996 to till now, they treated 96 million people. Then we come with the eye care, because actually if you have no hand or one leg is not with you, you can survive. But without seeing anything, you cannot survive. So because only the cataract surgery is enough to give light of your eyes. So we just started secondary level and primary level eye care service through our Grameen Healthcare Service Limited. Then we thought that we are working with primary, secondary, what is next? Then we try to establish one tertiary hospital. We started to set up a tertiary hospital with a 700 bed, 500 seat capacity medical college, 750 seat capacity technology institute. Actually, due to a lot of regulatory issues, it is delayed. Otherwise, it is impractical, but we'll finish our hospital within 2027. In the meantime, Professor Yunus it was his feeling that we have huge shortage of health workers. Then we set up nursing college. Now it is the #1 nursing college in Bangladesh. But with this primary, secondary, and tertiary, still it is difficult to serve huge number of peoples. Then we tried in 2019 to set up digital healthcare. But we failed to do it because our plan was not right. Still, we are not only the failure companies. No one can give their example that digital health is still a viable things. But we never give up. We start again last year with the name of Grameen Digital Healthcare Solution. And we bring Arman as a CEO over there. So actually we launch our digital health Shuki apps end of November last year. In the meantime, the figure is changing every time. 2.8 million subscribers we have, and 1.4 million are paid subscribers over there. So actually digital, any part of any corner in the country or any part of the world, you can give them service. But in Bangladesh, you know, the smartphone user is still very less than 40%. Then what they will do, those who have no smartphone, then we make an idea that we will set up Shuki Sheba Kendra, Shuki Service Center in the different corner in Bangladesh, different areas in Bangladesh. We just choose pharmacy. In Bangladesh, 100,000 pharmacy just we got from the different sources. So 5,000 Shuki Sheba Kendra already established. We give them a note where people will come and they will connect with us. If even those who have no handset or near Shuki Sheba Kendra, they can dial 10657. Then immediately you will connect a doctor. And you know the normal in our Shuki services, if you call with a general doctor, you need to pay only 20 taka. Then he can appoint or she can appoint a specialized doctor if he need. So in this way, we are trying to make an ecosystem, primary, secondary, tertiary healthcare. Just due to time constraint, I'll just give one example. So one is in Middle East. He booked a doctor for his father who is living in rural areas. So doctors is telling you need to examine your blood. They can go directly to the Kullan Health Center or they can get this service from Shuki. Digitally on-call diagnostic is there. Medicine you need, online medicine service is there. Ambulance service is there. So actually this way we are trying to make a whole ecosystem to serve the peoples, not only Bangladesh. In globally, we can through our platform. That's all.
Thank you, sir. Thank you so much. As I said, we could talk about more than 30 minutes about it. So this is wonderful, monumental, and we all should know about how social business is the most efficient path to ensure healthcare for all. With the interest of time, I would love to ask the last question to the honorable advisor here, because I know about an initiative that is actually addressing the whole 3Ds of democracy, demographics, and digitalization project. I would love you to talk about it, how you are not only connecting the rural and the bottom of the pyramid, also serving the urban. So in 3 minutes, sir, if you could give us this practical, the audience, the practical experience, that will be giving us a huge boost.
Okay, thank you. Yeah, we absolutely, we are, it's that, as you know, that is that we are going through a transition and transformation. For that matter, actually, we are trying to be inclusive. And towards that direction, all of us know that there's very little primary healthcare facilities in urban population. So we are really focusing on urban population with a comprehensive primary healthcare, and that is completely digitized, and that we may name it as a GP clinic or something like that, and that will be the hub for primary healthcare of a region like a ward or something of a significant population of 150 to 200,000 people. And that will be around service for 12 to 13-hour service for two-day shift. And that center will also have limited essential diagnostics, that is ultrasonogram, echocardiography, ECG, and basic biochemical tests. In addition, it will have some pharmaceutical services as well. So that will actually a comprehensive care, and that will be under a single umbrella. As you are talking about unique health ID, actually this will be an initiation of the unique health ID, though we already have UHID, but that is not exactly extending up to a greater, deeper length of health. So this unique health ID actually will capture the information that will constitute approximately 60% of the national ID, what we name it national ID right now. That is actually a voter ID that is not exactly reflecting the information ideally required for national ID. So what we think is the initiation of this primary healthcare for the urban population in a digitized environment with single hub for every primary health unit. That may act as the initial point of UHAID, which will lead to completion of the ultimate NID or social ID, whatever you name it.
This is the best example of how democracy steers innovation, demographic demand, and how digitalization delivers scale. We are almost at the end of the session. I'm so sorry that we couldn't utilize the full potential of our honorable speakers, but I'm sure they are here. You could ask them questions. I think as we wrap up, we have three takeaways of this plenary session. One is democracy in healthcare isn't just about voting. It's about voice, inclusion, and shared decision-making. And demographics are not destiny. They are actually a design challenge. And finally, digitalization must be human-led, but to be truly impactful. Thank you so much for your kind patience. And thank you so much to the honorable speakers to be part of this magnificent plenary. Thank you so much. We would like to take a group photo, and I would like to have Gupta on the screen so that we could have.
That's right. Could we please have the group photo at the back as well? And I request all the panel speakers to please maybe come on in front of the screen to just take a photo. We'll do one sitting down, and then we'll have you guys stand in front as well. Thank you. Thank you very much. If we could please ask all the panelists to please come in front of the stage to have a photo taken from the floor here. Could we have a huge round of applause for this wonderful group of panelists who have been very generous in giving us time, and of course, Dr. Gupta as well, who's joined us online. You have our eternal gratitude for making time for us. Thank you.
Thank you so much.
Thank you. Thank you very much. Thanks to all our plenary session participants. We deeply appreciate this. Thank you. Ladies and gentlemen, this is where we call it a break. You've been extremely patient. We've moved around a bit. We are breaking now for lunch, for prayers, and a visit to the marketplace. Please make sure you visit the marketplace. We've got a few wonderful social businesses and Nobin Uddokta stalls there as well. We've got book stalls, etc. Have your lunch, enjoy, network as much as you can. We expect you're all back here at 2:20 p.m., please. 2:20 p.m. is when we return back to this hall for a 2:25 start. requesting everyone to please return at 2:20 p.m. for a 2:25 p.m. start. Thank you very much. Hope all of you guys have a wonderful, wonderful networking break. Thank you.